Hi, everybody. Good evening. My name is Dr. Mary Claire Haver. I am a board certified obstetrician gynecologist, a certified menopause specialist, as well as a certified culinary medicine specialist. And I'm coming on live tonight and will be joined by the incredible Dr. Rocio Salas Whalen. Dr. Whalen is a board certified endocrinologist. She's also board certified in internal medicine and obesity medicine. We are so thrilled to have her joining us because she is really my go-to person for all things obesity, weight loss, and GLP-1 medications. So she is, hang on, I'm looking for her. Okay, let's see. She will be jumping in soon. So what we're going to be talking about tonight are the changes in how we classify obesity. Welcome.
Hi.
Dr. Salas Whalen. So happy to have you here with us tonight. So why don't
Thank
you,
you.
I just quickly said who you were and what you did, but just give us a brief kind of background of your training and kind of where you are now.
Um, I'm an endocrinologist and also obesity board certified doctor, and I specialized in weight loss, in the complexity of weight loss. Right, it's truly a specialty of its own, and with the new medications, we're getting more sophisticated in the way that we treat weight loss and the way that we see weight loss, not just as dropping the pounds in the scale as we used to do that, right?
Right. So I've seen the headlines. I've seen all the social media posts about how we are changing the way that we classify obesity. So what does this mean for you as a clinician and for your patients in real life?
I mean, really, I think is what I've been doing clinically for the last few years and what I've seen, um, that the best way to truly not miss potential patients that may benefit from early intervention or treatment, right? What this new classification of obesity is trying to move away from the BMI, which I think it's something that we've been trying to do for a couple of years. Even the American Medical Association last year said that the BMI should not be used as a diagnostic tool to diagnose or classify obesity. Right. So now this commission of 56 experts and more than 70 medical organizations have like accepted it. They're saying that the BMI should not be used anymore to classify or diagnose patients, that we should use a one body measurement, either waist circumference or hip to waist ratio, which those can be done very
In
easily
office.
and very economically, and or direct fat measurement. That is what we can do with body composition, with MRI, with DEXA scan or impedance machines, right?
Okay.
So now
But
those are what we're going to use.
I can't tell you how many patients have come to my office and even, I mean, I'll be honest. I was trained in the era of calories in, calories out, and that BMI defined obesity. And I still memorize those charts. I can still pass those on the board exam of what is overweight, what is obesity, and what is morbid obesity.
Mm-hmm.
We have relied on this, Dr. Whalen, for decades. Like since my first day of medical school, this was an issue. I feel that this is going to be really hard to undo. But, in your medical opinion, since you were living in the space and actually haven't been using BMI for years, how does the new approach move beyond, BMI, and why is this shift so important?
You know, I think we have to be responsible, right? As doctors, we need to be responsible of our treatment, of our approach with our patient. And I think I think everybody's feeling comfortable to prescribe weight loss medications, right? I think every specialty doctor or PA, nurse practitioner, med spa, they're feeling comfortable prescribing this medication, but we have to do it responsibly, right? For the benefit of the patient. If we don't use these tools to measure body fat, we're not serving the patient the right way, right? Because again, we patients were losing weight, which was muscle and body fat, and we maybe we're making the patient more metabolically unhealthy, right? By losing significant amount of muscle and not necessarily visceral fat or percentage body fat. That is what can make a person sick, or that's why we're trying to reduce the risk of disease, right? So I always say, if you're going to jump into the field of obesity medicine, which I encourage it, and there's not enough of us for the number of obesity people suffering obesity, but do it responsibly, right? Do it responsibly, even with a measuring tape, just measuring waist
Mm-hmm.
circumference, the hip to waist ratio, or truly investing in a body composition machine, right?
So, can you explain to my followers how you would, if you had a tape measure at home, how you would do a waist to hip ratio?
So you're going to measure your narrowest. So for the waist, it's going to be the narrowest point of your waist, which is usually above your belly button, with a measuring tape that is loose, not too tight. And then the widest part of your hip is going to be the second measurement. And you're going to divide the waist over the hip, the number that you get over divided your waist over your hip measurement, and then the result is what it's going to tell us. And in men, 1.0 or above of the ratio is high risk, right? Meaning that
Okay.
there's a high uh, fat mass in this person, and in women is 0.8.
0.8. Okay. Is there a number at which you're not worried for women? 98% of my followers are women. So, and most of them are around our ages, in their 30s, 40s, 50s, 60s. So, is there a number at which you would check a waist hip ratio and say, you know what, I think you're good
0.8, 0 in women, and 0.9 in men.
in men? Okay. Good to
Now
know.
we consider like low risk.
Everyone's going to be digging in their sewing baskets tonight to
Mhm.
try to get out their tape measures and do their waist hip ratio.
Yeah.
Okay. So on social media, and I just did this the other day, still today, even with everything that we know now about obesity being a multifactorial de- there are people clinging to the narrative that this is about willpower, and the stigma around someone who is struggling to have their weight be at a healthy level. Can you talk about that and where you think this new classification and these new medications are going to be
I
helpful?
think it's going to help to remove the stigma, especially from healthcare, right? Because healthcare holds the highest stigma in regards to obesity, unfortunately. So I think that by classifying obesity as a disease, then we can think more as other chronic conditions that we treat. And when we think of diabetes, when we think of hypertension, we think of treatment, or beyond lifestyle intervention. That's always part of anything that we do in medicine, but also seeing it potentially to use medication in the patient, right? And removing the burden on the patient to do it, achieve the result by themselves, right? I think what I've learned through the years is that patients were actually doing what they're supposed to be doing, or what we were telling them to do, to the T. They were following.
Hmm.
They can give us lectures on diets that we probably haven't heard, right? They have been doing the legwork, and it was just not happening because that's not the cause of obesity, right?
So
We know it's.
I love how you frame when I've heard you say it before, and I'd love to have you do it for our listeners today. What causes obesity? What are the causes?
So it's multifactorial. There's not a single factor that is causing obesity, right?
But what
We're
if,
talking.
your trainer at the gym or your boss or your well-meaning coworker says, just work out more and eat less. Come on, it's not that hard.
Oh, we need to educate them. We need to. I had an attending always in endocrinology that I would say, but how can they be saying this? Well, then turn it into a teaching moment, right? It's multifactorial, hereditary. It's a big part. So even
Genetics.
genes in what you like of food can be passed and passed down, right? So hereditary, meaning some sort of polygenetics. Then we have obesogenic environments, urbanization, industrialization, the food industry, sedentarism, working from home, right? Endocrine disrupting chemicals, plastics, BPA, that all can promote obesity. Then we go into hormonal changes, right? Or PCOS, thyroid disease, perimenopause, menopause, and then aging, right? That's another cause or high risk of obesity is aging because our metabolism slows down because we start losing muscle mass, right? So, and then lifestyle. But you see, when we try to just treat obesity with lifestyle, it has to become so restrictive to
Mhm.
overcome all the other causes of obesity that is not sustainable long term.
Okay. Do you think that this new definition of obesity, taking the BMI out of it, is going to make access to care easier or harder for patients?
Easier because now a patient that may have, that we would say has a normal BMI, but by doing direct fat measurement with either at home or with body composition machines, we can see that they may benefit or require treatment. Right now,
Okay.
the new diagnosis for obesity also ask for the patient to have either one or two of the following. One is that there's evidence of decreased organ function due
Okay.
to the excess
For
fat.
example,
So
like,
fatty liver,
okay,
right? Type 2
non-alcoholic fatty liver
diabetes, yeah.
disease.
Type 2
Hmm.
diabetes,
Hmm.
osteoarthritis, sleep apnea, right? Just to name a few.
Yeah.
Um, and or decrease mobility or decrease in daily activities
Wow.
because of obesity or because of the weight, right? Like to getting up, getting out of bed, going to the bathroom, just the daily day-to-day activities that become difficult because of the excess body fat.
Okay. Tons of questions tonight about GLP-1s, obviously. So let's dive into that. Um, they've been making headlines. You can't go anywhere on social media or anywhere reading about the new medications that are coming down the pipeline, the ones we currently have.
As they
Um,
should,
can
as
you
they should.
explain in the simplest terms how they work? You do this injection and then what happens?
So to begin, people need to know that GLP-1 is a hormone,
Hmm.
right? We make that hormone in our body in our small gut. What we have commercially that we see Ozempic, Wegovy, Mounjaro is a synthetic form of the hormone that we make, right? Like some people take thyroid hormone, it's a synthetic form of the thyroid hormone that we make. The difference is that they changed something in the molecule that made it long,
Okay.
like extended release. What happened?
I'm going to laugh so hard because the same people, and I might get in trouble for saying this, but I don't care, who have maligned synthetic anything, maligned, like,
Oh yeah.
oh no, it's not natural, I won't put it in my body, are injecting themselves with compounded GLP-1s left and right, and it is completely synthetic.
No,
There is my
yeah,
point
yeah,
being,
yeah.
you
I know
can't throw
your
out the
point.
baby with the bathwater. There are places for all of these things.
And I
And
remember in COVID with the vaccine,
yeah, these people
I
were like,
had patients
oh
that say,
no, it's
"No, I'm
artificial,
not
it's
putting
not
that in
real.
my
Those people.
system, but put me the Ozempic." I used to say, we tell patients that in the vaccine there's Ozempic, everybody will want the vaccine.
Okay.
But okay,
Okay.
we don't want to get political.
All
But
right. So,
but yeah, there are
yeah, not
synthetic
political. So
forms.
I've only been using GLP-1s in the last year and a half, 2 years max. You have been using these medications for over a
Yeah,
decade,
since
and as
2010.
an endocrinologist treating diabetes. So walk me through when you first started using these meds before they were popular or whatever. You have type 2 diabetes who probably weren't controlled on metformin, and here's this new medication. Tell me about this patient experience and how that really changed the way you thought
Oh
about
my
things.
God, I remember clearly. First, the patients on their follow-ups, they were coming with better glucose control, but with weight loss. And this was something so new in the diabetes treatment because most, if not all, the diabetes drugs that we have cause
Weight
weight
gain,
gain, right?
insulin.
So
Yeah.
it was very hard for us to treat sulfonylureas, except metformin, right? But metformin is, I would say, is weight neutral, but not necessarily causes weight loss, but it won't cause weight gain. But any other medication for diabetes will cause weight gain. So it was very hard to treat. We knew that obesity contributed to the patient's type 2 diabetes, but either we treated one or the other. We didn't have a drug that would treat both things at the same time. So it was huge. So when patients were coming back, not just with better glucose control, but with weight loss, then we started using it off label
Okay.
for weight loss, because the beauty of this medication, of this hormone, is that it only works as a diabetes drug if you actually have diabetes, meaning your sugar has to be abnormally high to go in the pancreas and produce more insulin.
So what your point is, and what I'm trying to, I think that some people might miss is that some of the drugs that we use to treat diabetes can drop your blood sugar into hypoglycemia. But this medication, there's very little danger of
It's
that. It will
glucose
only lower a high
dependent.
blood sugar to normal, never take a normal to
Exactly.
hyperglycemia,
It's,
which is key. Insulin does that. Sulfonylureas do that. You know, it's
yeah.
so hard to manage the lower blood sugar range on those older medications for
So they
diabetes.
don't cause hypoglycemia like other type 2 diabetes drugs. And that's the reason we can use it in people without diabetes, because it's not going to cause
Okay.
hypoglycemia.
So, who is the best candidate for a GLP-1 and who is not a candidate? Who would you hesitate to give it to?
I mean, the only absolute contraindication, if we go by health risk, right? We have one absolute contraindication on who cannot use this medication, is somebody with personal or familial history of medullary thyroid carcinoma.
Right.
Papillary thyroid carcinoma, no problem. Follicular hurdle cell carcinoma, no problem. It's exclusively medullary thyroid carcinoma. So that's the absolute contraindication that we have for this drug. Now, pregnancy, that will be another, somebody who's pregnant, we wouldn't be able to
And
use
that's
it.
probably, yeah, we have to test if it goes across the placenta or not. You know, it's a
I
little
think
iffy. Definitely for pre-pregnancy counseling to get someone to a healthy weight before pregnancy. I can see as an obstetrician, that would be a huge indication
I think
if,
it's going to eventually be used in pregnancy. The only thing that I think we need to be careful in those cases is going to be that the woman is eating enough calories,
yeah,
right? While
especially if she has
pregnancy.
hyperemesis, you know, you can't use it. You know,
Exactly.
she's losing weight on her own. Hyperemesis is nausea and vomiting in pregnancy. That's severe nausea and vomiting in pregnancy. Okay. Um, a lot of fear around this medication. I'm seeing it in the comments. The most of the fear
Mm-hmm.
is coming from people who have made billions, millions, thousands of dollars selling weight loss programs, who are trying to demonize GLP-1s because it's undercutting their business. What are some myths about GLP-1s you want to clear up?
That you become addicted to it is, I think it's one, right? That you become addicted to it, and once you stop it, everything goes. You regain more weight than what you had. It doesn't cause addiction, right? Obesity is a chronic disease. We're not curing it, we're controlling it with the medication. Same thing would happen in somebody who has diabetes. They're on medication, their glucose is controlled, we stop it, their sugar goes back up. Hypertension, we stop the drug, the blood pressure goes back up. Similar concept with these medications, right? It's controlling, not curing obesity. I think that's the biggest one. Weight, muscle loss, that you go on this drug and you're going to lose 40% of your muscle. Yes, if you're not doing it with the right prescriber, with the right doctor or the right healthcare provider, right? If they're not talking to you about muscle, about increasing your protein intake, about weightlifting, then yes, you're going to have significant muscle loss. But the drug itself does not cause muscle loss or hair loss. It's
It's
a decrease of protein in
in your
your diet,
diet.
right?
Uh, so what do you say to patients who, and I see this all over the internet, who worry about being on, and we have it in our clinic too. They're hesitant to consider the medication because they don't want to be on it forever.
Well, I think it's things are changing, right? Before we used to say no, well, if you stop it, you're gonna regain the weight. We recommend it long term, but every patient is different, every case is different. I do feel like one of the biggest predictors if you're going to need the medication long term or not is the patient's personal history of their weight or obesity, or their personal reason that brought them to the point that they need weight loss medication, right? So patients that had obesity since childhood and they're in midlife or in their 40s and their 50s and their 60s, so they struggle with obesity for decades, most likely they will need some sort of dose for long-term maintenance. But if you have, I'll give you my case, my example. I had two consecutive, I've never struggled with weight. I always weightlift and had a very high protein diet. Then I got pregnant with my first one and then got pregnant again in 5 months. So I gained significant amount of weight and then I entered my 40s as soon as I gave birth. So I had 40 extra pounds. I used it temporarily for about 6 months and I have not needed it for 8 years, right? Because I've been able to maintain, but I never struggled with weight. So again, it depends on the story of the patient. The biggest chance of not requiring the drug long term is maintaining or gaining muscle mass in your journey. Those patients that lose muscle, that don't gain muscle, it's very hard to bring them down from high doses because the medication is doing the full job. But when they build muscle, the muscle takes over the weight loss or the right increasing the metabolism. So if a patient really doesn't want to be long term on it, the best bet is muscle mass.
Okay. So 50 years ago, obesity was only in about 10% of the population in the US. So there's definitely obesogenic things that have happened in our environment as a nation. The way we eat has changed, the way we exercise has changed. We're a lot more sedentary. Our jobs are less physically
Yeah,
demanding, what we
yeah,
do all
yeah.
day. The convenience foods, the packaged foods, a big part of, good or bad, of this MAHA movement, and I'm not saying I'm pro or against it, so I'm not trying to be political, is this idea that we shouldn't need GLP-1s because we just need to fix the food, especially when they talk about children. They're like, why are we talking about
Mm.
giving a child a GLP-1 rather than fixing the schools, the food that is served to them in schools? A controversial topic, but you have more experience in this than most people, than anyone I know. How would you address this?
I mean, I do think that we have to address the food industry, right? I think that's the pink elephant in the room. And I do feel like the food industry will be held accountable at one point, like the tobacco industry,
Mhm.
right? Because, but in the meantime,
Yeah,
what do we
that's a
do,
big ship to course
right?
correct. And kind of
What
that's
do,
my point.
it's
Like,
a
it's a
monster,
monster,
right? It's a
there's a whole
multi-billion
generation of
dollar
humans
industry.
that will be left
Exactly.
behind while we fix how we
It's
feed
going to
and
take
move.
2, 3 generations for us to see the benefits if it would change at this moment, right?
Okay.
But in the meantime, we have to help patients, right?
So in my clinic, we are screening, as I'm sure you are, we're doing a HOMA IR score for everyone. So we're basically screening for insulin resistance outside of the A1C. And when they screen positive for insulin resistance, even though their blood sugars will still remain normal, it's a red flag for us. We start them, we give them nutrition recommendation, my background in nutrition, we try diet and exercise and HRT and whatever they need first. And then when they come back, if they're still insulin resistant, and we recheck everything and we look at muscle mass and fat mass, do you feel like insulin resistance on its own is something to consider, or is it just fat mass for GLP-1? Lots of conversation around whatever the hell microdosing is, and you and I have talked about this. It's not a thing. It's just you're getting medication,
If somebody
right?
has insulin resistance, they have high visceral fat. If somebody has high visceral fat, they'll have insulin resistance, right? So, I mean, they go basically hand in hand. So I do feel in those patients, we're already seeing organ decrease in organ function, right? If with insulin resistant. So if you have your measurement of direct fat measurement, then you have the reason for treatment.
So what I'm seeing in my patients is once they start this medication, they have never been able to make the lifestyle changes. Like they shop on the outside of the aisle, they shun the convenience foods, they are eating cleaner and healthier. And it's not because I told them
Exercising.
to, because I've always told them to. They are excited to exercise, they're motivated. It's the most incredible thing.
It's
You know, of
beautiful.
course, we
It's
spend an hour
beautiful.
counseling them about muscle and muscle loss and protein and all the things, because we are, you know, we don't want them to lose that significant amount of muscle mass, and then they end up metabolically less healthy than they were to begin with. So
It's a beautiful thing to observe and to watch. And I see this, many patients come to the first visit thinking of something external, and then somewhere halfway it flips and is more how I feel, how I look is more how I feel than how I look. Once a patient feels strong and healthy, there's no turning back,
mhm.
right? Many times patients physically, once they start losing weight, they can start working out. They're more flexible, they're lighter, they feel more comfortable going to the gym. So for many patients, weight loss has to happen before they adapt those lifestyle changes. And also, once they're on this medication and they start losing weight, they remove the pressure of exercising for
Weight
weight loss.
of
That
exercise,
is
yeah. That's huge. They're
huge.
exercise. They like in our
Huge.
clinic, they are exercising to make a bigger body, not a smaller
If they
body.
remove the
And they're
stress and
eating
the pressure
for
from
more
exercise,
muscles, not less fat. You know, it's just like, and they're fighting. You know, the appetite goes away with the GLP-1, so it's they're not craving. They're not. You know, they're like, okay, I've got to eat my protein. I've got to eat my plants. I need my
yeah,
veggies.
yeah.
Yeah, it's really, really, really exciting to see.
So
Um,
actually, these medications that people say, that's another myth, is like, oh, they're taking the easy way out, they're cheating. Oh God, no, it's work. Anybody who goes on this medication to achieve the health result, the metabolic health results that we want, it's work. It's
Can
work.
you talk about the kind of ongoing studies, and you know, FDA just got approved for FDA to treat
Sleep apnea.
sleep apnea, and in females, sleep apnea is not usually obese. They don't snore. They present very differently than their male counterparts, which is why they're missed all the time.
Yeah.
So can you talk about, you know, the non-weight loss benefits that we're starting to see with GLP-1 patients?
I think one of the biggest one is it has an anti-inflammatory effect. And I'm sure you hear this from patients. Many patients experience or express feeling better or less swollen even before the weight loss starts to happen, right? And the medication or the GLP-1 has direct effect on the inflammatory markers. It decreases inflammatory
Mm-hmm.
markers. By decreasing visceral fat, you decrease also inflammatory markers. And also, because the reward from food is taken away, we consume less inflammatory food or pro-inflammatory food, right? So it's a big combo, and it reduces inflammation. But we're seeing it for alcohol abuse, right, or for
Right.
alcohol addiction, or for other addictions.
I've
I
seen a
have
couple
many.
studies come out looking at depression as
I
well.
have many patients that they send me from a addiction center, that they gain significant weight because of the medications that they're on for the addiction, right? And the patients express that they feel a decrease in the drive for not just alcohol. I'm talking hard drugs, cocaine, heroin, and they feel less of a drive of the addiction. That patients want to stay on the medication because it feels like it brings it down, right? So addictions, Alzheimer, dementia, cardiovascular disease, renal function, fatty liver, and the big one is reduce the risk of cancer,
Cancer because of
obesity
inflammation. We're
induced. Yeah,
very excited. It's going to take a few years, but to see the reduction in breast cancer, which I'm pretty sure is
we're going
coming.
to see a reduction in everything, in type 2 diabetes, and hypertension, and cardiovascular disease, and osteoarthritis, and back
And
pain.
with that will be a decrease in dementia and a decrease probably in osteoporosis, as long as they keep on the muscle mass and keep moving their bodies, you know.
But that's why
So
that we have to, they have to be educated consumers, and that's what we do, and that's what I do every day, and that's my why, is education. We have to, the patient that knows more does better.
Um, so think about how we managed obesity before. Lots of gastric bypass surgeries, which temporarily worked for a lot of patients, but rarely were they able to maintain that loss long term. I recently heard not more than one, at least 3 or 4 people tell me who've had gastric bypass and then considered a GLP-1 because the weight came back on, that their doctors told them, well, you just should have another gastric surgery because, yeah, I mean, I think it's crazy. They're just trying to hang on to their livelihood because you're just never going to be able to get off the meds and the weight will come right back on.
If you think about it, a patient that gets bariatric surgery loses most of the weight the first 3 months. How much of that is muscle mass?
No one cared.
They
No one
even
cared before because we weren't measuring muscle. We
exactly.
weren't.
So all that weight that they're having so quick, how much muscle is the patient losing? Is the unhealthiest way to lose weight. And look, I've had patients that lost 170 pounds on these drugs, right? So that I really don't see the need of bariatric surgery. I mean, I remember the last time I referred somebody for bariatric surgery with these medications because we can control the rate of the weight loss to minimize muscle loss with the medications. With the
You
surgery,
can't.
we can't.
You can't. Yeah. So the bariatric surgeon told her the same thing. It was a money loss for him, you know.
But
If
you know
you
what?
could
Many
tell,
bariatric surgeons are diving into the GLP-1s. I see that a
I really
lot.
hope,
A lot of bariatric surgeons are now doing GLP-1s, which is it's great.
yeah. Um, what's the one thing you hope will change in the way we talk about obesity in the medical community? I mean, the stigma is real. And
Yeah.
let me tell you, I'm a physician, you're a physician. Physicians are some of the most unhealthy people I've ever met, you know? And it's not their fault. They live in an obesogenic world. The stress, the
Yeah.
hours, the, never been, you spent your 20s and 30s training and in medical school with, if you started a family or, it was
Working
really
nights,
hard. I
working
am
nights.
healthier at 56 than I ever was in my life. I work out on a more regular basis. I've never eaten healthier because I don't do convenience. I've really been able to build a life that I could not do in an insurance based practice because always someone had a gun to my head to stay longer, see more patients, do more, do more, do more, do more with less. And, since I stepped away from a broken system and built the clinic that I wanted and I knew would serve patients, my life is so much better. And I want every single woman to feel like I feel,
Yeah.
to
Yeah.
get up excited for the day,
Yeah.
can't wait to work out, can't wait to fill her plate with protein and plants
Yeah.
and all the things. And, but had I not left that practice and addressed my menopause and, really educated myself about nutrition, I wouldn't be here today.
Yeah. And for me in what I do, because I'm able to spend that time with patients, I can really listen to my patient, right? Because if you have a 15-minute visit, you don't have time to really dive deep in their story, their history of weight, especially with such a vulnerable subject for the patient,
Yeah.
right? That it's a conversation that you cannot rush. You're not going to build trust, right? You're not going to be able to educate patient. You're not going to be able to explain to the patient the medications or the lifestyle changes. So through being off insurance world, I've been able to. Everybody's like saying in the
Fix the
closet. Uh,
hanger. It's driving her crazy. There we go. It's the
yeah,
acoustics in here are so much better than the
we
rest
need
of
to
my house.
listen to
And my
basically.
dog.
Oh my God, look at him. We need to listen to the patients. Basically, we need to listen to the patient because only then you realize that the patient was actually doing what we're recommending and it wasn't working and it was not going to work.
Okay, so now I'm gonna talk a little shit about Novartis, but so why are the GLP-1 medications, the FDA approved ones, so expensive? Like, let them have it. You know what?
It's just not that. It's the environmental impact of the pens, right? I mean, I think the expensive thing is the pens, the manufacturing of the pens, because they're sophisticated pens, right? I mean, you use
But
them one time, you press a button, you dispose
okay,
of it.
Okay, so that's fair. But my point is, if you go to Norway, where it's
Yeah,
made,
anywhere
it
in the
is a
world.
quarter of the price. If you go to the UK, it's like $100 a month to get
Yeah,
the exact same
yeah,
medication.
yeah.
It's a little bit more expensive in Norway because the National Health Service, the NHS in the UK, bargained with, but in the US, it is 10 times. And do you know what it costs them to produce the actual medication? Is like $3.
A few dollars. It's abuse,
It's a
right?
47,000%
It's
markup. Yeah, so
it's
it's
a monopoly.
abuse.
It's an abuse. It's a monopoly, right? I think as more drugs come from different pharmaceuticals, the prices will come down. But it is a shame because you don't even have to say Norway. Anywhere outside the United States,
It's
it's a tenth
so,
of the
and
drug.
so this is where I think our government needs to step in, is get this price down. I think Medicare used to not be able to bargain with insurance
Yeah.
with manufacturers to get better prices. Now they can. Um, so, and then more competition's coming out and with different drugs that will help, supply and demand bring the price
Yeah.
down. But my goodness,
Yeah.
when
And
you look at the statistics and how they are, so there was a comptroller for one of the states, I think it was Virginia, and he said, I love GLP-1s, they're saving lives. And he ran the health, he was the treasurer, I'm sorry, for the state of Virginia, one of the states, and I hope I don't get this wrong. But basically, he said, if we had to pay the prices that these companies are demanding for the medication for everyone who needs it and would benefit from it, it would bankrupt the state. That is a problem. A 47,000% markup, and we're bankrupting state governments in order to get the medication to the people who really need it, who work for the state. This is the teachers, the firefighters, all the state employees. It would bankrupt them.
and
And
the
so when you,
opposite is happening in Denmark. They don't know what to do with the economy. Doesn't know what to do with the amount of money that the Novo Nordisk is bringing because it's in
it's
Copenhagen, which is
bigger than the whole
yeah,
country's
yeah,
gross national GNP, gross national product. I read
yeah,
that too.
yeah. So
Yeah,
it's
so much
like you
money
see,
is
it's
being
like
made.
exactly. But here, I mean, it's just hard to get, unfortunately. I would say more insurances are covering the
Uh-huh.
medications, right? And we always try to, if it's not tirzepatide, then we're going to do semaglutide. If it's not semaglutide, we're going to try to do tirzepatide. And then we flip from one to the other, depending what the insurance does. But I would say people still need to try to get it approved because many times insurances more I am seeing it through the years, more insurances are approving the medication.
So I'm going to open it up for questions just for a couple of minutes if you still have time. So
Hmm.
if you all have questions, drop them in the question box at the bottom. There's a little circle with a question mark inside. The comments scroll by so quickly.
Okay, it says compounded. Well, how do I feel about compounded GLP-1?
You're not a fan.
For me, patient safety is number one.
Mhm.
And if the option is to not prescribe it, then if it's I'd rather not prescribe it if it's not safe for the patient.
Okay. Um, so does it cause pancreatitis? I'm seeing that question.
No, I've never seen in my 14 years, 15 years of using this drug in patients, I've only had one patient with pancreatitis, and it was with liraglutide, which is Victoza, and it was in a patient with diabetes. But I've never seen pancreatitis in people that don't have diabetes because it's not touching the
Okay.
pancreas, really.
Lots of questions around, again, microdosing and losing 10 to 15 to 20 pounds.
One
You know,
one thing that I would say for the pancreatitis, I do not recommend, nor it's standard to check lipase and amylase just to see what happens, right? I'm seeing a lot of providers just checking amylase and lipase, which are pancreatic
he
enzymes,
needs,
just in case the patient has pancreatitis. Pancreatitis is not walking in the street. Pancreatitis is in the hospital, right? So
okay.
there's no need no
Right. Those are
need
the
to
sickest
check.
patients. Come
So
on, bud.
there's no need to check pancreatic
So,
enzymes. It's just confusing the
so,
patient. You're confusing yourself. Don't do it.
so what if someone is 10 to 15 pounds? Menopausal weight gain is around 10, 15, 20 pounds, usually in the first couple of years.
Hmm.
What about them? I see that that lots of people are asking.
My
Come on, bud.
question to that woman is, what of your day involves trying to lose those 10 or 15 pounds. Is it become a full-time job, right? Then it's warranted to use the medications. And many times when I have a patient saying, "Oh, I have to lose 10 or 15 pounds," when we do a body composition, surprise, it's usually 20 or 30 pounds, right? So don't assume until you have a body composition to know exactly how much you have to lose. And again, if it's 10 pounds, but it's becoming a full-time job that your body, your day revolves around it, then it's worth to be on the medication.
And you're giving them that piece of their life back. I
Exactly.
love the way you say that. That's one of my favorite. Do you think that I've seen this on the chat rooms because I'm OB, I came from the OB world, in polycystic ovarian syndrome, which is caused by insulin resistance.
It has,
Do you think there will be an indication for treatment of PCOS? I do.
yeah,
I mean,
definitely,
metformin
because
was used to treat PCOS, so why
it
wouldn't we?
still is. I mean, I don't even, but I mean, this
Oh,
is
what do we mean by body composition?
so a body composition is to know exactly what's what in your weight, right? Whenever we measure your weight in a scale, it's just giving us bone, muscle, organs, fat. We don't know what's what in your weight. So body composition is more precision fat measurement and also muscle measurement, which are your two most important things that we need to know, is your percentage body fat, your visceral fat, because those are the things that can make you sick and we want to try to prevent, and then your muscle mass, because that's your best metabolic organ. So body composition is going to tell us those three. So it's more precision measurement.
Can you take metformin with a GLP-1? I've never heard of that.
You can, but I mean, GLP-1 is metformin on steroids. There's nothing that metformin is going to do or help a GLP-1. GLP-1 are far superior, so you don't need to be on two and one kind of helpful drug and one 100% helpful drug. Just stay on the GLP-1.
Um, okay, so we're going to flip this around. A couple questions about menopause. Her doctor told her she's not a candidate because she hasn't gone a year without a period yet. Would you treat that patient in perimenopause?
With hormone replacement therapy? Of course. I mean, you can have a full regular period and be in perimenopause and benefit from the hormones and be completely symptomatic. Actually, once your period stops, most of your symptoms already pass, because symptoms can happen up to 10 years before your period stops. So, unfortunately, that's not true, and that's
Yeah,
wrong.
it's just said undereducated. Um, Undereducation of I knew more about obesity than I did about menopause as an OBGYN. I had given more insulin than HRT because that's what we treated gestational diabetes with in
Yeah,
my
yeah,
4-year residency
true.
program. That tells you. I probably gave out 10 times, 50, 20, 30, 100 times the amount of insulin that I did HRT in my
Yeah,
residency program.
yeah.
Do you think Medicare will soon cover GLP-1s?
Yeah, definitely. I think that's they're negotiating right now, and it is approved for cardiovascular disease, GLP-1. So if you can prove that you have cardiovascular disease, a GLP-1 can be approved by Medicare.
Okay. Well, reintroduce yourself because lots of people come in and out of these videos before we sign off. So they want, and you need to follow her, guys. Yes, this video will be saved on my page. And so before we sign out, tell everybody who you are again.
I'm Dr. Rocio Salas Whalen, and I'm a physician specialized in endocrinology and obesity medicine. And I practice in New York City, but I also do telemedicine. And follow me on Instagram. And I came with my own protein, my protein
Oh,
powder.
yeah. Tell us about your
My
protein. I had it
protein
all
powder,
week this week.
thank you, is Strength MD, and it came from seeing the need in patients, right? I when I thought of me putting my face, recommending a supplement, it's something that I wanted to believe 100%, and protein is one of them, right? And this is going to help to reduce the muscle loss. Um, And it doesn't have to be, I'm not saying my protein is going to stop muscle loss. It could be any protein. The difference in mine is that I added fiber because I was having patients complain of constipation because of the increase in protein in their diet. And also Ozempic or semaglutide causes constipation. So I added fiber and digestive enzymes to prevent that. So Strength MD is my other handle on Instagram.
Okay. All right, everybody. Have a good night. Stay warm. You're getting the snow now.
Oh yeah, we're
Right, in
having
New
a
York.
snow. I just came from
And
the
it
beach and not
actually is
snowing.
probably going to snow on Tuesday in Galveston, Texas, which happens like
Whoa.
every 10 years. So
Yeah.
we're getting ready. All right, buddy. My dog needs to come back in. Okay, everybody. Have a good night.
Have a good night, everybody. Bye.